So if you are suspecting an SIJ problem or that the SIJ is involved, the first thing you're going to do is perform 4 tests that are part of last cluster testing. And you're going to be looking to see if the majority are helping to rule in the SI joint. So the first one is gapping. So we're going to put our hands on either side of the ASIS, and you're basically just going to be pushing out, trying to gap the anterior part of the SI joint. If this test is positive as you gap, you're going to reproduce the patient's complaint of pain. And then if this is negative, you would move on to the thigh thrust. So now moving on to the thigh thrust, what we are going to want to do for this step is you're going to begin by bringing the patient's hip into 90 degrees of flexion. And as you bring the patient's hip into 90 degrees of flexion, you are then going to want to roll the patient away from you so you are able to place your hand underneath the sacrum. Once your hand is underneath the sacrum, roll the patient back and keep that hand placed underneath the sacrum. Now holding the patient into this flexion position, you're just going to do a quick thrust of her thigh to recreate or to create some pressure on the SI joint. A positive test would be if there is a reproduction of the patient's pain when you do this quick thrust in the position. So if both the gapping and thigh thrusts are positive and you reproduce the patient's pain, you can stop the test because 2 out of 4 have been positive. Now we want to move on to SI joint compression. So with this test, what we're going to be doing is placing our hands on the outer part of the ASIS, and then we are going to compress in or squeeze. So what I'm going to do is, as Jasmine's lying in this position, we are going to place our hands. I'm going to find iliac crest, find ASIS, and once I find that, I'm going to place my hands on the outer part of her ASIS, and then you're just going to compress or kind of push in. And a positive test will be as you push in if you get a reproduction of the patient's pain or complaints. If the patient is a bigger person and you feel like you're not going to be able to get proper movement or force, then what you can do is you can have the patients roll onto their side so they're in a side lying position. And then as they're in this position, you're just going to find iliac crest again to place your hands on to the ilium, and you're just going to compress straight down, getting that more inward kind of compression feeling. So the last part of the Laslet's cluster test would be what we call the sacral thrust. So you're going to start with the patient lying in prone, and you're just going to place your hands onto the patient's hip, finding iliac crest. Then you're going to move more downward and inward, so your hands are now going to be on the PSIS. Once you're on the PSIS, come down and find the sacrum. You're going to want to put the heel of your hand onto the sacral body, and then you're just going to thrust down toward the table. As you perform this quick thrust, a positive test would just be if you reproduce the patient's pain. So one test you could do if you're suspecting SI joint instability would be the supine active straight leg raise test. So with the patient lying in supine, you're going to ask them to lift their leg straight up. So as the patient lifts their leg straight up, if there is either pain when she does this motion or she has poor control, then what you want to do is you're now going to ask the patient to do that again. So she's going to lift her leg straight up, but as she does this now, you're going to want to come in and provide compression at the pelvis. And providing compression at the pelvis, you're providing stability to the SI joint. So you're going to ask the patient to lift her leg again, but this time as you apply compression when she lifts the leg, if it feels better or less painful or it is more controlled, then it would be a positive test indicating that there is form closure. If you want to test for force closure, which is more of a muscle problem, you can do the same thing. So just similar to what we did, you would again ask the patient to lift her leg straight up in the air. And again, as she does this, if it is painful or the motion is uncontrolled, have her bring it back down. Now what you want to do is have the patient cross her arms over her chest. And now as she lifts her leg, you want to ask her to bring her opposite head and shoulder up, and then you're going to apply resistance. This thus is creating closure, and again, if the test is positive, the movement is either going to be more controlled or less painful. But this indicates more of a force closure problem or more muscle involvement. So similar to the active straight leg raise test, you are now going to do the prone straight leg raise test. So same thing is done except the patient is lying in prone, and this is done if you're suspecting SI joint instability. So ask the patient to lift her leg up, and if it is painful or she has poor control, then she's going to lower it down, and you're going to do the same thing, asking the patient to lift her leg up, but now you're going to come in and provide compression at the pelvis, which will give some SI joint stability. So as you apply that compression, ask the patient to lift her leg up again, and if the movement is more controlled or less painful, that would indicate a positive test for form closure because you are now applying some manual closure, giving stability to the SI joint. Same thing can be done now if you suspect a force closure problem or muscle involvement. So you're going to do the same thing. You would have the patient lying in prone, and you would ask her to lift her leg up. As she lifts her leg up, same thing. If it is painful or there is uncontrolled motion, you have her lower it down. And now what you're going to do in order to provide a force closure, you would have the patient lift the leg up, and the opposite arm would come up as well. So as the patient lifts up her leg and the opposite arm, you want to apply resistance onto the arm just like this. And again, as she does this, if the motion is now easier to perform or more controlled or less painful, that would indicate a positive test for a force closure problem or muscle involvement. So again, a positive test is if the movement is easier to control or if the motion is less painful. So now we are performing the supine to sit test, which is a test for SI joint involvement that is going to test for apparent leg length. So as we test for apparent leg length, the first thing you want to do is have the patient lying supine. You're going to come over here and have the patient bend her knees, and you're going to hold on to her feet and basically just ask her to do a bridge. So she's going to lift up. This is just making sure that the pelvis is in neutral. Then you're going to ask the patient to relax, and you are going to pull her legs out. So once you pull her legs out, you're then going to place your thumbs onto the medial malleoli on each foot, and you're just looking to see if one is longer than the other. So as you do this, let's say in this case on Jasmine's right leg, it looks longer while in supine. So the medial malleolus then in this case looks more inferior. So as you're looking at this in supine, then you're just going to ask the patient to sit up, keeping your hands on the medial malleoli, and you're just going to re-examine. So now that the patient is in long sit, recheck, and if it looks like the right leg is now shorter, the medial malleoli being superior, this might be because the right innominate on that side is anteriorly rotated. So if there's an anterior rotation of the innominate, the right leg looks longer in supine, and then it would look shorter in sitting. Same goes for the opposite. So if her right leg was shorter in supine, but then when you had the patient sit up, it was longer in long sit, this would indicate a posteriorly rotated innominate. So if we saw either of the two things I just described being anterior or posteriorly rotated, this would indicate that there was an apparent leg length issue. So now we are performing the hip scour test, which is an assessment for OA, acetabular impingement, and labral tears, so looking at more intra-articular sources of pain. So you are going to test the uninvolved side first and then the involved, and what you're going to do is you're going to place the patient's leg into some hip and knee flexion, and you're just going to kind of wrap your arms around and kind of push down with your body weight to apply a little bit of pressure, and you're going to create a semicircular motion. So just make sure you're applying pressure and kind of moving the hip into a semicircle. And a positive test would be if you reproduce the patient's complaints of pain when you're performing this test. So now we are going to be performing a test if you're suspecting any hip pathology. So this is called the Faber test. So what you're going to do is you're going to take the patient's leg and you're going to be placing them into flexion, abduction, and external rotation. So have the patient take their leg and you're going to cross one over the other so that the patient's ankle kind of rests just above their knee, and you're just going to let the patient drop their knee out to the side. And you're looking to see how far the knee is from the table. And typically if you measure from the knee to the table, a positive test would be if it is more than 4 centimeter difference, which could indicate that there's an intra-articular problem. And then just also make sure that you compare it to the other side as well. So now another test we're going to be doing if there's a suspected hip pathology would be the Fader test. So for this test, you're going to be doing flexion, adduction, and internal rotation. So you're going to bring the patient into those motions, so flexion, then some adduction, and then internal rotation. And this actually closes down the joint. So this can often be painful or uncomfortable, but in order to be a positive test, when you put the patient in this position, you have to reproduce the patient's complaints or pain that they have been feeling. So now we are performing the flexion adduction test, which can also be done if you're suspecting a hip joint pathology. This test, though, is typically going to be done in the younger population, so you're typically looking at young adults or just older children. The plyometrics are not very good for older adults, just because as you get older, you may have limited range of motion. So typically do not use this on older adults. So what you're going to do is you're going to have the patient lying in supine, and you're going to place one leg on the table so that the hip and knee are flexed, and you're just going to ask the patient to bring their knee across their body, so you're trying to get the leg across to the opposite shoulder. So a positive test is if they can't bring their leg all the way across to the opposite shoulder. Then you want to just compare to the other side. There are also levels for this. So level 1 would be that the knee is able to cross all the way to the opposite shoulder. Level 2 would be it makes it about halfway. And level 3 is it doesn't move very much. You're not really seeing motion. And again, a positive test is if they can't bring the leg all the way across to the opposite shoulder. So now we're going to be performing the log roll test. So what you're going to want to do is with your patient in supine, you're going to place one hand on the femur and one hand on the tibia, and you're just going to be rolling into max internal and external rotation. When doing this, you're just going to be looking for symmetry when comparing the uninvolved and involved side, and also as you're rolling, you're looking to see if you get a spring back or a springy block going into internal rotation that pushes you out into external rotation. So a positive test could be if there's limited motion on the painful side, and this could suggest there's an intra-articular problem, but it does not tell you exactly what the problem is. You don't know what it is, but it gives you some idea that there is a suspected intra-articular non-arthritic hip joint pain. So now we are going to be performing the anterior labral tear test, which should be done if you're suspecting that there is a labral lesion or labral involvement. So basically for this test, the start position is going to be with the patient in full hip flexion. And then you are also going to put the patient into abduction and external rotation. So flexion, abduction, external rotation. And as you put the patient into the start position of flexion, abduction, and external rotation, then you want to move the patient into extension, adduction, and internal rotation. So again, start position is going to be hip flexion, abduction, and external rotation, moving into extension, adduction, and internal rotation. And a positive test would be if you reproduce the patient's symptoms or their pain with or without a click. So just because you have a click doesn't necessarily mean it's positive. So a positive test would be reproduction of the patient's pain. So now we are going to be performing the posterior labral tear test, which is going to be done if you suspect a labral lesion or labral involvement. So similarly to the anterior labral tear test, you're still going to start in full flexion, but your other two movements will be different. So start position would be full flexion, then adduction, and internal rotation. So again, start the patient into full flexion, adduction, internal rotation. Then you're going to want to move the patient out into extension, abduction, and external rotation. So again, start position will be full flexion, but with adduction and internal rotation, and then moving into extension, abduction, and external rotation. And again, a positive sign would be as you do these movements, you reproduce the patient's symptoms or complaints of pain with or without a click. So what we are doing now is called the Craig test, which is a special test to assess for alignment. So starting with the patient in prone, what you're going to want to do is to bend their knee to 90 degrees, and then you're just going to use the heel of your hand to feel for the greater trochanter. So what you want to do is, as I bend the patient's knee to 90 degrees, you want to internally and externally rotate until you feel the greater trochanter pop out into your hand, or when it feels that it is the most prominent. So as you're in this position where you feel that the greater trochanter is the most prominent, you want to ask your patient to hold this position as best they can. Then you're going to take your goniometer, and with your stationary arm at vertical and the movement arm is going to be lined up with the tibia, you're going to measure the degrees. So normal would be 8 to 15 degrees, excessive anteversion would be if it's greater than 15 degrees, and retroversion would be if it's less than 8 degrees. So now we are performing the fulcrum test, which is a special test done if you suspect that there is a fracture in the femur. So what you're going to want to do is place your forearm under the thigh on the leg that you are testing. And then as you place your forearm under the thigh, your other hand is going to come to the distal end of the femur just above the knee, and you're just going to slightly press down just like this. And a positive test would be if there is a reproduction of the patient's complaints or pain, indicating that there could be a suspected fracture. So now we are going to be performing the patellar pubic percussion test, which is typically a test that allows us to examine if we are suspecting a fracture of the femur, and typically this is the best test for suspecting a fracture. So you're going to instruct the patient to kind of feel for their hips or their ASIS, and to kind of move their hands inward until they feel like they are on a bony prominence, which would be their pubic bone. You're going to ask the patient if it is okay if you place the stethoscope here, and you're going to have them hold the stethoscope basically right on the pubic bone. And then what you're going to do is you would do the uninvolved side first and then the involved side. So you would do that both times, and then you would basically just kind of pull the skin down on the patella, and then you're just going to tap. And as you tap, a positive test would be if you hear a dull or more decreased sound. So you're looking for a dull sound instead of a clear, distinct sound. So a positive test would be if you have a dull sound, which would indicate possible fracture of the femur. So now we are going to be performing Eli's test, which is basically a muscle tightness test, specifically looking at the rectus femoris muscle. So what you're going to do is have your patient lying in prone, and as your patient lies in prone, in order to test the rectus femoris, you're going to bring her knee into flexion like this. So as you bring the knee into flexion, if her thigh or knee stays on the table, then the test is negative, meaning that the rectus femoris is not tight. But let's say that as you flex the knee, her thigh kind of pops up the table like this. So it pops off the table and there's some space that you can place your hand there. That could indicate that there's tightness in the rectus femoris muscle. So a positive test again would be as you flex the knee, if her thigh pops off the table, there may be suspected tightness in rectus femoris. So now we're going to be performing the piriformis test. So what you're going to do is have the patient inside lying, and you want the involved side up. So if Jasmine's complaints are on her right side, then her right leg is going to be the one that is up. So what you're going to want to do is, with the hip in about 60 degrees of flexion, you're going to want to take the leg and kind of let it drop off the table. And you are basically then going to apply a downward force to create a deduction and internal rotation, so that knee does have to drop off the edge of the table. And a positive test could be is if the muscle is tight, you will feel some resistance when doing that motion. If you want to apply more pressure, you can also have them resist external rotation. And again, if the muscle is tight, you will feel some resistance to the motion. The test can also indicate if the sciatic nerve is involved, so as you do this, you could reproduce the patient's symptoms or complaints in the sciatic nerve distribution area. That could indicate some sciatic nerve involvement because piriformis will be contracting. So a positive test could be that if you feel that the muscle is tight, you will feel some resistance to that motion. So now we are performing the Trendelenburg sign or single leg stance test, and this is a test for gluteal tendinopathy in patients with greater trochanteric pain. So typically you want to always do this test when the patient complains of lateral hip pain. So you're going to have the patient stand on the involved side for 30 seconds. And a positive test will be as she does this, you're looking for reproduction of the patient's pain or complaints, or for the hip to drop. So again, a positive test would be as she's standing on the involved side, it reproduces the patient's pain or complaints of symptoms. So now we're going to be performing the resisted external derotation test. So this could typically be a test if you're suspecting hip muscle pathology, more specifically in the lateral hip muscles. So for this test, what you're going to do is you're going to have your patient lying in supine, and you're going to want to put the hip and knee into 90 degrees of flexion, and you also want to do some external rotation. So you're going to support the knee with one hand just like this, and then you also want your other hand on the outside of the heel. So as the patient is in this position, you want to tell your patient to push and try to bring their leg back to neutral. So they're kind of pushing into the resistance while in external rotation. A positive test would be as you perform these motions that you reproduce the patient's complaints of pain or their symptoms. So now we are going to be performing the sign of the buttock test. So for this test, it is similar to the straight leg raise, in which what you're going to do is have your patient lying supine. You're going to raise the leg up, and let's say right here is where the patient has their complaints of pain. So if this is where it's painful, you're then going to want to bend the knee to put the hamstrings on slack. And when you bend the knee, you should be able to move her knee forward like this. So if her leg is able to move forward like this, it would be negative. But let's say when the patient feels their pain right here, you bend the knee to put the hamstrings on slack, and you are unable to move the leg forward, that would be a positive test. So a positive test would indicate if when you bend the knee, you are unable to move it forward. So now you're going to be performing hip long axis traction. So typically for this you will use a stabilization belt, but in this case I do not have one, so I am just going to be using this rope. So pretend it's my stabilization belt. So with your patient lying in supine, you're going to place your stabilization belt around, and you want it hanging low on your buttocks. You don't want it up above your hip. So make sure it's just kind of hanging low, wrapped around more so the bottom of your buttocks. You're then going to twist it so you are able to make a little circle and place your hands through it. Make sure when you do this you are grabbing above the ankle and not directly on the ankle joint. And as you grab above the ankle, placing your hands through there, just make sure your patient is scooted all the way to the edge. Wrap your arms above the ankle, and you're just going to sit back. And as you sit back, the belt in your hand should help to pull the hip into a long axis traction. So now we are going to be performing hip lateral distraction. So again, you're going to be using your stabilization belt, and you also just want to make sure that you have a towel. So with your patient lying in supine, you're going to flex the knee and the hip to as close as 90 degrees, and then you're going to place the towel on the inside of the patient's thigh or groin area. You can also ask your patient to place the towel here just if they're not comfortable. You're then going to wrap your stabilization belt around and make sure again that it is low on your buttocks and not up high on your hip. And then basically while supporting the distal thigh and knee, you're just going to kind of lean back to pull laterally through the belt. So by leaning back, you're now just pulling laterally, getting a hip lateral distraction while stabilizing the distal thigh and knee. So now we are going to be performing a hip anterior glide. So typically what you're going to do is this patient, you can have them lying in prone, which is typically more comfortable. You could also have them lying off the bed with their knee kind of flexed and up like I just showed, but for patient comfort, we're going to do it in prone. So you're going to put your stabilization belt around yourself like you're wearing a sash, and you want the belt to be on your shoulder, and then it's going to go around the front of the distal thigh. So you're going to place the belt on the patient's distal thigh, and you're just going to use the belt to kind of lift up as well as kind of stabilizing your hand just underneath the knee too. You're then just going to palpate and find the greater trochanter, and basically you're then going to apply a force through the proximal hand in the anterior direction. And again, I'm performing a hip anterior glide, and this can typically be used to increase extension and external rotation. So now I'm going to be performing a hip posterior glide, and typically this position, the patient is going to be in supine with their leg off the edge of the table. You want your belt to be around your shoulder, and then as you put the belt through the leg, you want it to be supporting behind the distal thigh. And then you're going to place your hand behind the distal thigh just to make sure you're supporting. And also make sure that the opposite leg is flexed with the hip and knee. So have the patient hold with their upper extremities. Then again, you're going to use your hand to apply a mobilizing force in the posterior direction. So as I do this mobilization, I am trying to do a hip posterior glide, which would increase the movements of flexion and internal rotation.